Welcome, everyone. My name is David, and I am one of the administrators of this group. We are so glad you could join us today for this special presentation of a Facebook Live with Dr. Matt Rosner and Dr. Debby Feinberg. Dr. Debby Feinberg is the founder of the field of NeuroVisual Medicine, an optometric subspecialty dedicated to identifying and treating subtle vision misalignments that cause neurological and medical symptoms and not typically associated with the visual system. These symptoms include headaches, dizziness, anxiety, and panic and persistent post-concussive symptoms, gait and balance problems, frequent falls, neck pain, motion sickness, nausea, and reading and learning difficulties. To date, more than 80 optometrists have been trained in neurovisual medicine methods and techniques and are now delivering this life-changing care to patients around the world. We also have Dr. Matt Rosner. He is a board-certified emergency physician who practiced for 30 years prior to retiring. He currently serves as the Director of Education and Research at the NeuroVisual Medical Institute. He has been actively involved in binocular vision dysfunction research since 2005 and in the neurovisual medicine training program since 2013. Dr. Rosner is co-author of multiple peer-reviewed publications on BVD and vertical hypophoria and has presented this research locally, nationally, and internationally. He played a key role in the development of the validating screening questionnaire that screens for BVD in patients being evaluated for dizziness. Together, they're sharing their insights, research, and real-world experiences, helping patients better understand and manage these often overlooked conditions. It is my pleasure to now welcome Dr. Rosner and Dr. Feinberg.
Thank you so much, David. We're really happy to be here and to share our work with your group. So we're going to move on to the beginning of the lecture. Here we go. So who are we? Well, this is myself with my husband, Dr. Matt Rosner, and my brother-in-law and sister-in-law. Arthur Rosner, at the other end, opposite me, is an ear, nose, and throat doctor, and he's actually the reason why I'm doing this work today. We were on a double date. He was holding up a loose prism in front of one of his eyes, and I said, "Who gave that to you? What is it doing for you?" He said, "Well, I was struggling in medical school, and the chief of ophthalmology thought it might be able to help me with my vision." I said, "Did it help?" He said, "Not the best." So I said, "Let me examine your eyes," and I did. And I discovered that he needed a small unit of prism. And that prism allowed him to read in a way that he had never read before and allowed him to no longer feel clumsy and klutzy. And this has launched this work over 30 years ago to binocular vision dysfunction. So what have we learned along the way? Well, in 1995, I identified that quarters matter. Small units of prism make a big difference in my patients' clarity and comfort with vision. In 1999, we identified that drugs actually interfere with the treatment, the narcotics, the benzodiazepines, the muscle relaxants, the vestibular suppressants, alcohol, and marijuana. In 2000, we identified that traumatic brain injury can actually cause BVD. And then in 2000, the screening questionnaire, the BVDQ, was developed. In 2010, identification was made of the physiology of vertical heterophoria, was updated and expanded with the discovery of VH. And then in 2017, identified that sound can actually impact vision alignment. Noise-canceling devices can be helpful. So what else have we learned along the way? Well, we learned that BVD is frequently diagnosed as something else. ADHD, anxiety disorders, triple PD, malingering, dyslexia, vestibular migraine, Meniere's, maldebarkment, and BPPV that's not resolving.
So, as part of this event, Many of you were kind enough to fill out the survey. Matter of fact, 304 of you were. So I've got the data here, and we're going to start sharing some of it with you now, and we'll be continuing to share it with you throughout the presentation. So in this cohort, 73% of you are greater than 50. There's a few folks that are younger. 93% are female, which is a very large number. We asked how dizziness impacted your life, and it turned out 83% of you are either disabled or a lot impacted by the dizziness. And you've been symptomatic for a long time. First symptoms were more than 5 years ago for half of you, and for 30% of you, it's been even more than 10 years. And then as a child, 45% of you noted that you had car sickness. So this has been going on for clearly a lifetime for many. Still searching for diagnosis, almost 40%. And amongst those, searching for more than 5 years, almost half. And searching for more than 10 years, a quarter. Now, I'm going to go through some symptoms, and just to make it easier, I've got numbers here, but anything that's highlighted in yellow is present in more than 50% of you. Depression's common, PTSD type symptoms, anxiety, sound sensitivity or hyperacusis, and light sensitivity. And I put asterisks next to everything but PTSD because those are all symptoms of BVD as well. Additionally, you have serious quality of life issues. Less than 4,000 steps taken in an average day by half. And by the definitions we could find, those people are highly impacted and very limited in their life. And being stuck in bed or immobile for more than 5 days a month was a third of you. Now, it's not like you haven't tried to get help or tried different therapies. Half of you have. I'm sorry. For vestibular therapy, 78% of you have. 40% for counseling, and 20% for vision therapy. And amongst those therapies, about people got a relief, about half of you did, but the other half not so much. And then lastly, there's other serious quality of life issues. And actually, I got this information from a survey I did the month before with a group called Vita Retired. And it turns out you seem to be almost as impacted as they are. So I'm using that data here. They had real problems with driving. They were either unable or limited, 70% of them. And then they found it impossible or challenging to watch TV, use computer, read a book, go grocery shopping, or walk half a mile. So clearly there's serious quality of life problems here. And then we also asked you what else you've been diagnosed with. So migraines, vestibular migraines, anxiety, depression, and triple PD. They're very high. But having said that, is this what you really have?
So oftentimes these symptoms aren't recognized as an eye alignment condition. They've been symptomatic for a long time. They have difficulty making the diagnosis or not really sure what you have, tried many different therapies, impactful, serious symptoms, serious quality of life issues, and inadequate relief with the current approach. And there have to be other answers. So here's one of the possible answers: binocular vision dysfunction. Eyes are struggling to work together in a coordinated fashion to see a single image. Most common form of BVD in our practice is not convergence insufficiency, but vertical heterophoria, where one line of sight from one eye is above or below the line of sight from the other eye. And here's an example of where one eye is seeing an image higher than the other eye. BVD as we know it, Mark, you want to say the stats?
Sure. It impacts at least 20% of the general population, but more than half of those with TBI symptoms that are lasting more than 3 months, more than half the children with reading or learning challenges, and a quote-unquote high percentage of those with persistent headaches and persistent dizziness. We haven't done those studies yet, but I can tell you that in our practice it's incredibly high. But then again, we kind of have some selection bias because people are coming to us because they have these symptoms, but it's not a small number of people with persistent dizziness or headaches that have this. Additionally, this is not vision therapy. It's an advanced use of microprism lenses. It's the basis of a new optometric specialty that we're calling NeuroVisual Medicine, which has been present since 1995, so we're 30 years into this. There's currently 80 trained neurovisual medicine specialists in the world that are using these advanced microprism techniques, and they're getting these kind of results, an 80% reduction of symptoms. Now, that's a large amount, but having said that, if they're not trained neurovisual specialists, they're not getting these results. And what do I mean by this? So I'm going back to the survey, and in the survey, about half of you, actually, more of you had seen an optometrist or an ophthalmologist, and we asked what kind of diagnoses you were given by those doctors. 68% of you were given no binocular vision diagnosis. And the binocular vision diagnosis that I'm really looking for is either VH, vertical heterophoria, or superior oblique palsy. And adding the two together, it's only 5%, but we know that at least 20% of the population has VH. So this is telling me that the current approach is missing this on a routine basis.
So now we're going to talk about the binocular vision dysfunction symptoms. The symptoms of BVD and vestibular disease overlap greatly. So we'll discuss the vestibular symptoms. There's dizziness, lightheadedness, disorientation in large spaces, vertigo, drifting to one side with walking, frequent falling, motion sickness, unsteady with walking, car sickness, lack of coordination, and clumsiness. Classic BV symptoms: poor depth perception, double vision, shadowed vision, amblyopia or a lazy eye, closing or covering an eye, overlapping vision, and asthenopia or headaches. Losing your place when reading, fatigue with reading, skipping lines, rereading for comprehension, trouble focusing, and slow reading speed. So while those were the classic BV and reading symptoms, it's what's below the surface that people didn't really think were ever going to be related to the visual system. So pain symptoms: headache, migraine, TMJ pain, neck ache, upper cervical pain, eye strain, sinus pain and pressure, and pain with eye movement. They're sensitive to complex patterns, light sensitivity, problems with reflection or glare, words vibrating on the page, increased visual sensitivity to motion. Psychological symptoms like anxiety, overwhelmed in crowds, agoraphobia, driving anxiety, overwhelmed in large spaces, panic attacks, suicidal thoughts, self-esteem issues, and trouble focusing.
So going back to the survey results, we asked what your top symptoms were. And it turns out that these are the top symptoms, and they're present in between 70 and 80% of you. Dizziness, vertigo, unsteady gait, glare and light sensitivity, sound sensitivity, anxiety, neck ache, and reading difficulty. By the way, these are all BVD symptoms too. So there's certain myths associated with binocular vision dysfunction, and that honestly is how not to identify them. So let's go through some common myths. The first one is you have to have double vision to have binocular vision dysfunction. And it turns out that only a third of our patients have what would be considered double vision, either doubled or shadowed or overlapping images. It turns out the other 2/3 don't, but they're highly symptomatic. Myth number 2, I just saw my eye doctor. Shouldn't they have found BVD? And the answer is current eye exams and tests just aren't sensitive enough to find the very small misalignments that are causing symptoms. And then the third myth is I have prism in my eyeglasses, but it hasn't helped much. And the answer to that is neurovisual specialists use prism in a way different way than traditional vision care providers do, and they don't get the same results. So it really does matter who you go see to get your prisms. On average, patients see between 4 and 7 professionals before their BVD symptoms get recognized as visual and being sent to a neurovisual specialist.
So what were the prior diagnoses or misdiagnoses? They've been told they have vestibular migraine, and when you see it in blue, it's the top survey diagnoses that were done. BPPV, Meniere's or atypical Meniere's, labyrinthitis, vestibular neuronitis, reading and learning difficulty, dyslexia. They were told they have migraines, muscle tension headaches, sinusitis, chronic neck pain and torticollis, extraocular muscle weakness, cranial nerve weakness, convergence insufficiency, and accommodative insufficiency. Psychiatric, generalized anxiety disorder, panic attacks, agoraphobia, ADD, ADHD, psychiatric dizziness, triple PD, chronic subjective dizziness, and psychogenic dizziness, persistent post-concussive symptoms, and malingering, just making it up. It's all in your head.
Does this sound like you? Does it sound like somebody you know? Because it might. So now I'm going to take you on a slight journey and go ahead and expose you to a vertical heterophoria simulator. Let me explain this. I have the next slide, and it's a picture of a lady, but she's been photoshopped to have two sets of eyes and two sets of lips, one above the other. And what you are going to do unconsciously is to try and merge those images. When you do that, that struggle makes about 75% of you symptomatic. And I'm going to ask, well, in a moment, how you feel. But having said that, let's do her for 15 seconds. Here we go. All right, that's about 15 seconds. And since this isn't quite as interactive as I would like, I guess I'll share. Many people will tell me that when they watch her, they end up feeling some dizziness or some nausea or some pulling or tugging in their eyes or some anxiety, even some headache and nausea. And with that in mind, that's just looking at it for 15 seconds and struggling trying to merge those images vertically. Imagine what it would be like if this was your existence all day long.
So what triggers or worsens binocular vision dysfunction symptoms? Visual stimuli like 3D movies, reading, action movies, certain wallpaper and carpet patterns, driving on freeways. All of these are forms of optokinetic stimuli. And then additional triggers, complex visual environments like malls, grocery stores, crowded rooms, significantly different prescription between the two eyes, monovision contact lenses, traumatic brain injury, intense near-point work, computers and reading, and then errors in prescription lenses. Surgery also, like cataract, LASIK, eyelid tightening, retinal reattachment, and monovision implants. So what are the causes of BVD or VH? It certainly can be from birth or congenital. It can occur from a traumatic brain injury or motor vehicle accident, from a traumatic brain injury from concussion, or acquired brain injury from stroke. Also, inner ear pathology, third mobile window syndrome. So what is the recurrent theme for these patients? Symptoms aren't being recognized as eye alignment condition. They're symptomatic for a long time, seen by many different care providers. Many tests performed, many medications and therapies tried, many procedures performed. Inadequate or minimal improvement.
Now, interestingly enough, I had a slide like this in the beginning that described your cohort, and here it is. And it turns out that this isn't very different than what we just did, and I'm going to overlap this slide with the one we just did. Here we go. They pretty much overlap. So I guess the point is that not only is this a theme for dizzy patients for the survey group here, but it's also common in binocular vision dysfunction patients too.
So now we're going to describe this new approach, NeuroVisual Medicine. We'll talk about the screening and the treatment. So how do we screen for vertical heterophoria? Well, we use something called the Binocular Vision Dysfunction Questionnaire. It has 25 frequency-based symptom questions, and it's based on the Likert scale, and it's been a validated tool to screen for BVD in patients being evaluated for dizziness and published in the Otology Neuro-Otology Journal. To date, there have been 100,000 BVDQ tests completed. The test only takes 7 to 8 minutes to complete. We also have it for children who are 9 to 13 years of age and 4 to 8 years of age. Everyone has a BBDQ score, including you. A BBDQ score of 15 or above is highly predictive of BVD and successful treatment with microprisms.
All right, so here's eye-ear connection number 1. We're going to go over the results of the Binocular Vision Dysfunction questionnaire from the 304 of you that completed the data. And it turns out, once again, a score greater than 15 is indicative of needing assistance or further evaluation. 96% of you scored greater than 15. Remember that the general population is, this condition is present in about 20% of them. So it would appear that in your cohort, binocular vision dysfunction is definitely a possibility worth checking out further. Now, I actually cut it down to those that had scores greater than 30 because clinically for us, if the score is greater than 30, those individuals are highly impacted. And 2/3 of the group had a score greater than 30. So if you need to go and find the questionnaire again for either yourself or a friend, it's at www.isitmyeyes.com. And I'm going to ask that this get posted in the comments section so that you can copy and paste it if you wish.
So now we're going to talk about the NeuroVisual clinical protocol. It's to date been used to treat over 100,000 patients across the US, Canada, and Australia. So what is the course of treatment? There's an initial evaluation of 80 minutes with a progress assessment 2 to 4 weeks later that is 50 minutes in length. It's approximately 2 visits over 2 months with annual appointments needed after that initial treatment. So the initial evaluation is a detailed history with symptom presentation. We use the BBDQ, we screen for POTS, we screen for third mobile window, screen for hyperacusis, and then we have a symptom severity index.
That's the 0 to 10 questions. How much nausea, how much anxiety on a 0 to 10 scale.
So what are the 4 physical findings of vertical heterophoria? So we're looking for facial asymmetry. You can see that this young girl's eyebrow, the left side, is higher as well as her eye on that side. And this is a condition called hemifacial microsomia. Also very common, you'll see a head tilt in the patients. You'll also they'll describe neck and upper back pain. And what are those optometric BV findings? We do a comprehensive vision exam for eye health and refraction and over 17 binocular vision tests as well. And then we look at their inner ear findings during the exam as well. And we do this through gait and balance analysis. We ask the patients to rise from seated to standing position. We observe their gait down a long hallway. Are they drifting to one side with ambulation or wobbling from side to side? We observe them with head turns while walking. We call it the supermarket walk. So we're about to show you a common patient in our office, one that we see very commonly every day.
So Heather's been in a car accident. She's got persistent post-concussive symptoms. And we're going to do those 0 to 10 questions on her. And this is her baseline 0 to 10. You'll notice there are 4 or more on all of these symptoms. She's very symptomatic.
If I were to ask you to sit up or stand up from the seated position, let's see what happens. How does it make you feel when you first stand? Go ahead and take your time. Upon rising, how do you feel? Let's fall over. Let's walk the hallway. Come on with me. Okay, go ahead.
So you can see she's listing off to the right and then she corrects.
And then come on back.
And again, almost falling into the vertical rack.
What happened?
And I started to feel unstable and go to the right, and then I started to correct myself, and I still kept on moving myself to the right.
After having a microprism placed over her left eye only a few minutes prior, Her symptoms have significantly improved. Dizziness went away, anxiety went away, nausea went down from 6 to 2, headache went
Let's see what
away.
your gait is like. I'm going to pull back from you and ask you, upon rising from the chair, see how you feel upon rising. What's your first impression?
Stable and fine and able to get any food.
Without any symptoms? Let's do some hallway walking. Let's open the door. Perfect. And let's walk down the same hallway.
You can see her gait's a little faster and she's straight down the middle with the prism.
Come on back. Stopping right there, what did you notice?
I don't go to one side and I feel stable walking. I don't feel any kind of dizziness or if I'm listing to one side or another or trying to compensate while I'm walking, and I'm able to walk faster.
So microprism works immediately, and there's immediate and significant impact on gait and balance and symptoms. We also work during our exam with sound attenuation testing, which we'll discuss later in the talk. There's a therapeutic prescription we custom fit with a visual orthotic device real time during the exam using these quarter adapter microprisms. Then we refine the prism prescription to reach comfort and clarity. During the 2 to 4 weeks while they're wearing their first prescription, they go through something called progressive relaxation. Those eye muscles were very tight, and with that first set of prism lenses, there's relaxation, and the whole body relaxes as it adjusts to their new alignment. When we see them for the progress assessment, we do what we call a fine-tuning exam. The symptom presentation, usually their binocular vision dysfunction questionnaire, will significantly improve, and during that test, we review some of the original testing, then we fine-tune their therapeutic prescription with prism and refraction. The results: 50% average improvement with the first exam and 80% average improvement upon completion. It also leads to improvement with their other rehab therapies in work and school, and reduction and elimination in some cases of the medications they were using.
So usually we're able to help people with this if they come in with a high score, but not always. And sometimes they have other things going on as well. So for example, if they've got an inner ear issue, it could be third mobile window syndrome, which we're just about ready to come up to discuss. And they're going to end up getting referred to a neuro-otologist for care. They could end up having POTS, and if that's the case, they're going to get referred to an EP cardiologist. And if they have true migraines, they're going to get referred to the neurologist. So let's take a minute and talk about POTS. This is a condition called Postural Orthostatic Tachycardia syndrome. And it may not be so well known, so I want to spend a minute reviewing it. It's a form of dysautonomia, which autonomia is your body's automatic controls, things like blood pressure and heart rate and breathing. So in this patient cohort, when they stand up, the blood is not automatically shunted up from their legs to the rest of their body. It stays in their legs. So what happens is the blood pressure drops, which causes lightheadedness and dizziness, and they may even pass out. And the body's response to this is to increase the heart rate at least 30 beats per minute when they're standing, which will stabilize the blood pressure and get blood to the brain, but it'll also make them feel not good by doing this. Okay, there's a number of management strategies, and they're aimed at increasing the circulating blood volume, and that includes being really hydrated, a lot of extra salt, wearing compression garments on your legs to squeeze the blood out of them and not let the blood pool in them, exercise to improve your cardiac function, small frequent meals so the blood doesn't go to your gut instead of the rest of you, cooling strategies. That just means it can't get too hot. If they get overheated, they also then go ahead and get a fast heart rate. And if they're really symptomatic, if they just sit back and elevate their feet, they feel a lot better. And of course, avoiding triggers. And there's a whole host of medications, which I'm not going to go over tonight. Now, going back to the survey results, we asked 4 screening questions with regards to POTS. And it turns out that half of you answered yes to at least 3 or 4 of those questions. And it's been our experience that 3/4 of those, 75%, will end up having POTS. So if you're answering yes to these questions, you really need a POTS evaluation with the EP cardiologist. I want to review another condition that gets confused with BVD, and that's vestibular migraine. So 55% of you say you've been diagnosed with vestibular migraine. It's defined as having dizziness with headache with no other causes identified. Usual treatments include medicines for migraines, vestibular therapy, and CBT, but I'm not sure what the results are with regards to disabled or severely impacted individuals. I suspect not the best because they're still searching for relief. So the thing to keep in mind is that dizziness and headache are actually common BVD symptoms too. So you really need to rule out BVD, and I would start with using the BVDQ to screen. And then this other condition called triple PD, or persistent positional perceptual dizziness. 28% of the group was diagnosed or told they had this. So when you look into it, the linchpin of the diagnosis is visually mediated dizziness. That means you have to be having dizziness made worse by seeing things or through the visual pathways. The treatment for this is antidepressants, vestibular therapy, and CBT. Once again, I don't know how well it's working with disabled or severely impacted people because they still seem to be pretty bothered. Having said that, visually mediated dizziness is a common BVD symptom. So once again, I think you need to rule out BVD and just be screened with the BVDQ to start with. And then I want to show you a few slides and discuss fine motor control. So people shake or have a tremor and they have trouble drawing, and it's felt to be just a motor condition, so a problem with their muscles or the brain controlling their muscles. But we're finding out that vision plays a role in how you draw, and it would make sense. So this is a 7-year-old girl. She's attempting to draw a picture of the optometrist, and she tells me that her vision is wiggly and squiggly. So she did have vertical misalignment. She was given a trial frame with microprisms and then redrew the picture same day. And that's what she drew. And the wiggly and the squiggly was gone. So she didn't have a motor deficit or a brain problem controlling her muscles. What she had was visual misalignment and shakiness that was causing her to not be able to draw straight. I have another picture of a young boy who was trying to draw a peacock, same scenario, and then afterwards was able to draw the peacock like this. So you're going to be asking at this point in time, how does this work? What's going on with your binocular vision? What's the physiology of all of this? And it turns out there's 2 main concepts we need to cover. The first one's fusion and the second one's alignment. So fusion is a phenomenon where the brain synthesizes a single image from the images received from each eye. Now, it's a high physiological mandate with evolutionary survival value. Take a look at the bear. It's really important because by fusing an image, it makes sure you don't see double. So if you're seeing double, which bear is the one that's the threat, the one on the right or the one on the left? Also, it produces a single, stable, 3-dimensional image and allows depth perception, which would come in handy if you're trying to hunt the bear. And then lastly, it anchors the visual, vestibular, and proprioceptive integration. Those are the 3 neuro inputs with regards to balance and gait. And that comes in real important if you need to escape or run away from the bear. So clearly, fusing an image is very important. Now, image alignment is the necessary precursor to fusion. And the eye muscles, the cranial nerves, the vestibular ocular reflex are all the 3 main inputs, and the brain is acting as a central processing unit. Let me go back to the vestibular ocular reflex. That is a reflex from the inner ear that sends messaging to your eye muscles to keep your eyes aligned when your head moves. So when you're walking, your head goes up and down 1.5 inches each time, but you don't know it because your eyes are going in the opposite direction to balance that out. So when it works, it's great, but when it's faulty, it's a problem, and I'll come back to this in a moment. So let's just show this with a cartoon. We have two eyeballs, a left eyeball and a right eyeball, and they're both looking at the same image, which is a tree. Those images get sent down to the brain, and those images are completely overlapped, which allows the brain to very easily combine them into a single fused image. But what happens when you have a misalignment, in this case a vertical misalignment? Well, the images go down to the brain, but they don't overlap. They're off by a bit. So the brain can actually force them to be seen as a single image, but it takes a lot of energy. So there's a defective visual alignment input somewhere, and it's causing an energy-intensive and inefficient process. Now you have to struggle to get that image to fuse, and it takes longer, which takes more time than the proprioceptive or the vestibular processing time, and those are the other two inputs for balance. So it's like driving a car where one wheel's kind of got the brake stuck a bit and it's not spinning as fast as the other three. It's not efficient. And all that energy gets used up trying to do this. Well, it takes it away from thinking, speech, and balance. So people complain of brain fog. That's the thinking problem. So how are symptoms caused? Well, truly, we are struggling to maintain a fused image. It's not coming easily. The eye muscles are getting overused, which is causing pain. So that's like headaches or face pain. The misalignment and the realignment, which is what's going on, causes vestibular or dizzy type symptoms, nausea, car sickness. The mismatch between the visual inputs and the vestibular inputs is what causes the anxiety. Misalignment of the images causes double vision, and then the head tilt to correct the vision misalignment causes the neck pain. So let's spend a minute on research and academic activities. We haven't, this has been 30 years in the making, and this is really important information, and people just aren't going to take your word for things. So we actually do research and publish articles. The first article I want to discuss was the validation study, and it was validated to screen for binocular vision issues in people undergoing a dizzy evaluation or workup. So it was published in Otology and Neurotology in 2021. We've also published on TBI studies because our first cohort of people was those with traumatic brain injury. So in Physical Medicine and Rehab and Brain Injury Journal, both of which are top-tier peer-reviewed journals, and it basically noted that treatment of the binocular vision dysfunction with microprism lenses led to a marked decrease in symptoms. Then there's a third mobile window study, which we did with one of our favorite colleagues in Louisiana, Dr. Giannoli, and it's ended up showing that there's an association between noise canceling and third mobile window, and that those that responded to noise canceling devices in this study, this group of patients, actually had problems with third mobile window and responded to either medications or surgery. And then we worked with a group that was working on maldebarkment, and the takeaway message from that article was that the symptoms of maldebarkment and the symptoms of binocular vision dysfunction overlap greatly.
So to summarize, these patients are actually hiding in plain sight. Binocular vision dysfunction, BVD, appears to be present in up to 20% of the general population, up to 50% of all TBI and acquired brain injury patients with persistent symptoms greater than 3 months, and then 50% of those with reading and learning challenges. The symptoms of BVD are not being recognized as being visual in etiology despite extensive testing and consultation. These patients are seen by multiple providers, yet don't get much better with standard treatments and therapies. Treatment of the BVD with realigning prismatic lenses reduces symptoms by 80%. BVD suspects can be easily identified with the BVDQ. BVD can be firmly diagnosed and prescribed by the NVM examination protocol. Standard binocular vision tests are not sensitive enough to identify this patient population. Traditional vision evaluations are not sensitive enough to identify these patients. Which children can potentially be helped? Children with reading and learning difficulties, LD, RD, children with difficulty concentrating or hyperactivity, ADD or ADHD, children with motion sickness, car sickness, children that are clumsy and uncoordinated.
And it's easy enough to just use the questionnaires and sort them out. So I'm now going to touch on this third mobile window syndrome that we described a little earlier. And this is going to be the second eye-ear connection. So I have this young lady. She was born with third mobile window syndrome. And I want you to just hear how she responds to the microprism lenses and the noise canceling devices. And then we'll chat about the condition a little bit more.
Maybe if you could tell me a little bit about what happened when I put the headphones on you earlier today.
When you put the
Before our exam began.
when you put the headphones on, it was a complete release from my head to my toes. It was like every nerve in my body, I could feel it just release. It was like getting 100 massages at the same time. It was complete peacefulness. I felt like my brain could finally shut off.
If you think about when your symptoms of sound sensitivity began, how far back does it go for you?
It goes as far back as I can remember, because I remember being 2 and 3 years old, getting a patch on my eye and getting vision therapy and feeling dizzy and feeling nauseous.
And was the vision therapy helping your dizziness and your nausea?
No, it didn't.
And how about sounds when you were little girl?
Sounds the same thing. Everything was. I just remember everything being loud, but it's always been that way for me, so I didn't know any different.
And how does it feel now not to have all that extra sound?
It's beautiful. This is beautiful. I don't ever want to take these off. This is wonderful. It's yeah. Right. It's
Yeah, just a relief.
It's just finally it's almost like finally being able to rest.
Yeah. So I'm going to have your husband take the video, and then you can take her right now just so you can see her. And I'm going to take off, you're looking at the sign on the counter.
And how's the sign looks clear.
We're going to take off the prism glasses.
Okay.
Close your eyes. And then put these on your own glasses. And what's your first impression?
Oh, it's very jumpy. It's really jumpy. It's hard to focus. And my eyes twitching.
And she's looking at this sign over here on the counter.
My right eye was twitching and I couldn't focus. And the words were jumping around a little.
And how does it make you feel when you look through these?
And I'm a little dizzy. My left eye hurts. And I actually feel nauseous.
So each piece of the puzzle is playing into your symptom changes, because if you
It doesn't even look like the words are straight.
he's gonna take over for you again. Close your eyes.
You can close it.
So now she's got the glasses back on. And how's it feeling now that your own glasses with prism are back on?
Now they're fine.
Wonderful.
Now they're fine. Everything's in a row and everything is fine.
And how's the nausea?
Right.
So it sort of went away that quickly.
Yeah.
Now what happens if you take off the headphones and you're looking at the sign? What happens to the sign?
If it's fuzzy, if it's fuzzy, it's a little hard to focus, but it's doing okay. And the lighting are on, but nothing. And my left eye starts to hurt.
Anything else?
Now we're going like this and really. It's going up and down.
So the letters are moving on the side.
The letters are actually moving on the side.
And if you put the headphones back on, what does that do to the movement of the letters?
They just stand still. They stand still.
So in this patient's case, it was congenital. From birth, she had these symptoms. But in our office, it's pretty common presentation that this sound sensitivity and vision misalignment come together in a large number of our traumatic brain injury patients. The eyes and the ears are connected, and malfunction of either can cause visual and vestibular dizziness symptoms. Both microprism lenses and noise-canceling devices work immediately. So what are the symptoms of third mobile window syndrome? Well, hyperacusis is one of them. They're sensitive to sound, more sensitive to sound when compared to their friends and family. However, the majority of patients are not even aware that they are sensitive to sound, which is why we test every patient with a noise-canceling device.
Okay, so now we're going to go ahead and do a little bit of anatomy here because I'm sure you're all dying to wanting to know exactly how this works. So I have a picture of an inner ear, and starting from the left side of your screen, you can see what looks like an eardrum, and it's connected to bones that are then connected to this blue inner ear. And it has two components. One side on the right that looks like a snail shell, and that's called the cochlea, and that's the hearing side. And then the side on the left, which has these three semicircular canals, and that's the balance part of the inner ear. So this entire inner ear is supposed to be surrounded by bone. But if you have third mobile window, you end up with either a hole in the surrounding bone, which is called a dehiscence, or a leak in those windows, the round or the oval window. It's called a perilymph fistula. In any case, once the pressure inside the ear isn't stable because of these leaks, it allows sound to cause a vertical visual misalignment through that vestibular ocular reflex I talked to you about before. How do you treat this? Well, the first thing you can do is reduce sound input. And you can use noise canceling devices, you can use earplugs, musician's plugs. There's a number of different devices we use to reduce the sound going into the ear so it won't send that dizzy signal. Also, if you can reduce the pressure in the ear, we used medications like diuretics, which is what they use to treat Meniere's disease. It allows the healing of a hole or a leak. And then lastly, if none of this is working enough, surgical repair for the hole or the leak is considered. But you need to know that these are hard to get to, and not every one of them is amenable to surgery. So, going back to our survey, we asked the group about third mobile window symptoms. And same thing, we asked for screening questions. And it turns out 27% of the group answered yes to 3 or 4 screening questions. And about 3/4 of these will have third mobile window. So with that in mind, you need further evaluation for third mobile window, and that would be with a neuro-otologist. I want to share with you a research project we did in the office. We never published the data, and it's with 30 patients that we found out had third mobile window syndrome. And what we did is we got their 0 to 10 scores on dizziness, nausea, anxiety. I can't read it. Oh, there we go. Headache, neck ache, unsteadiness walking, and light sensitivity. And you'll see that they were all running between 4 and 5 for starters, on average, amongst the 30. But look what happens when we put the noise canceling device on them. That's the aqua columns. It goes way down, more than half. And then the tan column is the symptom relief they get when microprism lenses are added in addition to the noise canceling devices. So clearly, it's very impactful on symptoms. All right, so we're rounding the corner here. This is the summary. If you're still symptomatic with dizziness and experiencing severe impactful symptoms like depression, PTSD, anxiety, sound sensitivity, glare or light sensitivity, and neck ache, and If you're experiencing severe quality of life limitations like trouble with driving, watching TV, using a computer, reading a book, going grocery shopping, walking half a mile, or stuck in bed for more than 5 days a month, and if you've been told you've got ADHD, anxiety disorders, triple PD, lingering dyslexia, vestibular migraine, Meniere's disease, nail debarkment, or BPPV that just isn't getting better, your evaluation is not complete without assessment for these treatable entities. Remember, in this group, 96% people screen positive for BVD and need further evaluation. And just as an aside, 2/3 scored highly impacted. You need evaluation for POTS. Half the group screened positive. Third mobile window syndrome, 1/4 of the group screened positive. And hyperacusis as a symptom was present in 75%. So, this concludes our presentation for tonight. This is the information on the Padlet where we've included all kinds of resources. That folder that I showed a picture of, it's a brochure on POTS is there, and there's more information there as well. And information from VITA is there to help with your search for dizziness, cures, and information. Also, this is the website where you can get more information about neurovisual medicine. And here's a link with regards to how to find a specialist that does, that's been trained to do neurovisual medicine. And I'm going to ask that this all gets copied and pasted into the comments section. This is Picasso. Picasso drew almost all of his paintings in adult life with facial asymmetry, which really makes me wonder what was going on with him. And this is my name and my email. So I'm going to leave this up now. Dr. Debbie and I are going to stay on to answer any questions you may have. So please feel free to use the comments section. And let's just see what you got. I see one question here right now. I read that having microprisms can make the eye alignment worse and needing higher and higher prescriptions or causing lazy eye in the long term. Is this true? And it turns out it is not. So it's a phenomena that people call eating up prism. And there was a study done in 1953 by a researcher by the name of Ken Ogle. And what he did was he gave small amounts of vertical prism and kept going until people couldn't keep the images together, until they saw double. And they were able to go 2 increments. We call them diopters, which is a fair amount. And we're working in quarter increments. So with that in mind, it turns out that that was normal people. But with people like our folks, this never happens. We've seen in our office probably more than 25,000 patients with binocular vision dysfunction and vertical misalignment, and it has never once happened that we've had problems with people requiring more and more prism. Let's see here.
Should we try vision therapy first before getting microprism? So my suggestion is, what's nice about being evaluated through the neurovisual medicine protocol is if you're going to be helped, you will know that first visit. You will actually feel the relief and you'll know you're on the right track. That's just one visit. There will be one more for follow-up. But vision therapy can take many, many, many months. So in terms of thinking about expedient outcome to get better quicker, certainly having a neurovisual medicine evaluation, filling out the BVDQ makes the most sense to have that as your first step.
Next question. Do I need follow-up evaluations? So it turns out when you go to an optometrist for glasses, it's really a good idea to get checked once a year to see if the prescription is maintaining itself or if it needs to be adjusted. An adjustment is actually pretty common at the year mark. Well, it turns out that with binocular vision dysfunction and microprism, that is also true. So an annual evaluation is a good idea and it's recommended.
But this patient hadn't had the follow-up. If they're doing well, they don't need that follow-up. But most of our patients, if they've never been seen, their first visit is not their final. Because of that progressive relaxation, they need to be seen one more time for completion of the care.
Question, if there's anybody that's going to be joining the network in New England soon,
We actually have a doctor coming in December from Vermont. So thank you for asking. They asked if there was some in the New England region. Just a fun fact, in January and February, we're going to have a doctor coming from Singapore, and we're going to have someone coming from Sweden as well.
Waiting on other questions if they're there.
Would binocular vision disorder present a large enough challenge that vestibular therapy would not work as expected for bilateral vestibular hypofunction?
So I would answer that question by talking not about vestibular hypofunction as much as vestibular therapy. And it turns out that if you really have binocular vision dysfunction that's ongoing, it's going to be very challenging for vestibular therapy to be effective because the BVD interferes with the treatment. So I don't know with respect to bilateral vestibular hypofunction, but I do know that vestibular therapy is done best once the binocular vision dysfunction is taken out of the equation.
If we wear readers or glasses for distance, how does that work with microprism? When people need prism, we call it a visual orthotic. They're actually going to need that prism in all corrections. The alignment needs to happen at any distance that you're viewing at, whether it be far or near. I have superior canal dehiscence. I had surgery in 2022, but continue to have a lot of dizziness. How do I know if it's just a failed surgery or if I have another problem like BVD? Again, we always start with the questionnaire, so filling it out. If your score is higher than 15, then it's worthwhile to have an evaluation to see if there may be a vision explanation for your remaining dizziness. My peripheral vision has greatly decreased. Is that also from BVD? That is hard to say. These are all cases where we certainly need to see the patient and see what's going on. In our traditional neurovisual evaluation, we always test for peripheral vision to see how well are they seeing out in the periphery. Sometimes when there's so much stress on the system, the eyes just tend to overconverge and almost feel like they're having tunnel vision. So again, this would require a detailed neurovisual evaluation.
I had migraines, so I'm wondering what neurological damage could mirror BVD. I don't know about that, but I would say that if you've got migraines, how well are you being treated? How well are your symptoms improving? And if they're improving adequately, that's wonderful. But if not, I would wonder whether or not there's an underlying other condition like third mobile window syndrome, binocular vision dysfunction, or POTS. So start with taking the BVDQ because that's the easiest and it's accessible through isitmyeyes.com.
And one of the things I like to say is, as long as we've been doing this for over 30 years, the goal is certainly to do our work the best we can. But then if we aren't able to help patients, we're always looking for the other reasons why they're not doing well, which is why we got involved with POTS and seeing if we could peel off that layer, third mobile window syndrome. So we're always looking for, if I can help you just so far, now where do I need to send you to get the rest of the way better? My vestibular disorder has caused me to get oscillopsia. Although it has improved after 10 years, I still suffer from it. Is there any reason why it was not included in your survey? Well, I always have it. Is this damage to my vision permanent? Again, without an evaluation, it would be difficult to say. It is not common in our office that we see patients with oscillopsia. We have seen patients with it. It can be quite debilitating. But even in my patients with oscillopsia, between the tints that we use that can calm the nervous system with the sound cancellation devices and any kind of update to the refraction with prism, we can sometimes calm down the speed of the movement and the motion.
Explain the difference between visual vertigo and BVD. I think I would consider visual vertigo more a description of a symptom. That is, motion detected by your eyes is causing dizziness. In the original description of visual vertigo, they don't actually have a reason why that symptom exists. Having said that, they've now rolled that into the diagnosis of triple PD. And having said that, binocular vision dysfunction does cause dizziness related to visual stimuli. So I would once again want to know whether or not this is binocular vision dysfunction and not what they consider visual vertigo.
I'm going to read this question. I have bilateral Meniere's disease, vestibular migraine, and triple PD, complete hearing loss in my right ear. Due to so many ear infections in my left ear, the ringing is consistent. So my medical doctor told me after examining me that my left eardrum isn't moving at all. It's no good. Also, it's about to go out. Do you know much about the cochlear implant? No, that is something I would refer you to a specific otologist who's well trained in cochlear implant work. That would be a neuro-otologist. My vestibular therapist says that my eyes show nystagmus in all directions, so she can't really tell what kind of BPPV I have. My OT also says that my eye muscles are weak, and she can't tell the moment I begin to get a little blurry-eyed or dizzy. Is my dizziness, lightheadedness issues with stimulation and lights due to an issue with my eyes, my ears, or my brain? I have vestibular migraine, visual nystagmus, and recurring BPPV. Please help me find a solution. Again, I would strongly recommend that you fill out the BVDQ, and many of the symptoms that you're describing are worthy of evaluation to see if we can quiet the symptoms down, peel off the visual layer, potentially an auditory layer, and see if your symptoms reduce.
What we're finding that's really interesting in these complex patient cases where they've got multiple inner ear pathologies, sometimes there's actually a simple root cause answer, and sometimes it's this vision misalignment. And if you don't have that assessed and taken care of, it will still look like all these separate diagnoses. So the easiest way to figure this out for us has always been use the questionnaire first. And then if it really ends up sorting out that way, then going for further evaluation.
How can you explain the rapid results of feeling better immediately upon trial lenses in your office?
That's actually pretty easy. So the eyes, okay, seeing double is a major problem. Your body will do whatever it can and struggle not to see double. So there's a huge fight going on trying to keep your eyes aligned. As soon as you use the microprism lenses, you've realigned the images. So now they're no longer misaligned. The eyes might still be not properly aligned, but the images are right. So the body stops struggling immediately to try and realign the images, and that leads to an almost immediate reduction in symptoms. All right, the image you showed of the inner ear, if there was an inner ear nerve damage, that means that could cause BVD. Did I understand you correctly? So it's usually not damage to the nerve. It's usually damage to the surrounding bone around the inner ear. So it sits in a bone, in a bony cavity, and it can be thin in places or even missing. So when that happens, the pressure from where that bone was dividing from now attacks or attaches to the inner ear, and that's what causes the dizziness. So it's not a nerve issue so much.
What can you do for flicking eyes, as I'm suffering with them constantly and they're causing really bad headaches, but I don't know what to do? And again, I will go back to the BVDQ. We've used that now for over 20 years, and it will identify whether or not there's a visual piece to your symptoms. Sometimes people's eyes are just constantly moving because they're not coordinated, and they're just going back and forth trying to align. So again, we might be able to identify that starting with the BVDQ and all that effort that's being exerted, like Dr. Mark was saying, to coordinate the eyes can actually cause significant headaches, which can be relieved with synchronization of the images. And this looks like this will be the last one before the live event. This is my swaying and rocking and imbalance started after total knee replacement. Could there be a correlation between nerve damage in my leg and vestibular disorders? And vestibular therapy, going to PT for neck misalignment, going on for over a year. I just listened to one of the ICU podcasts, which they talked about sometimes people are given a medication that can actually cause some vestibular problems. So this is a complicated question, and whether or not it's connected to your visual system or how it can be helped is a great question. I would say being evaluated by a neurotologist would probably be quite helpful to make sure there's nothing being missed in that deep inner ear structure if there was damage done.
One more question.
When I'm in a car at night, the car lights, porch lights, look like they have 5 circles within the light, almost like a flower. So that can happen from uncorrected astigmatism, that can happen from misalignment of the eyes, that can also happen from multifocal implants put in following cataract surgery. So that's a great question, many possible reasons.
And actually, too, if they have cataracts, can't they get the dispersion phenomena?
Yes.
Okay. Well, I know we're posting no more questions. I think we're done here. So Debbie and I want to thank you very much for your attention this evening. And I want you to know, one more time, look at the comments. We've given you a couple of links to go ahead and get some more information. So the whole purpose of tonight's event is really to just provide you with information and different thoughts and avenues to pursue. If you haven't checked these different things out for you yet, and it sounds like you, then you should definitely do it. There's a possibility that these different entities, BVD, third mobile window syndrome, POTS, might actually be the avenue for you to improve your dizziness.
We want to thank Hollie and Dave Morrill for their tremendous help in allowing us to bring this knowledge forward. Thank you again, everybody, for attending.